Perfect. Nice to see you, man. You're looking shredded. Holy crap.
Yeah, I'm leaner.
How many, I think somebody told me you're doing a 4-in-1, like a fat refeed every fourth day. Is that
Yeah, I
right?
mean, it was something. It was when I need to. Basically, I think you can't go too long without
Yeah.
getting essential fats in, and I still eat a fair amount of fat, but it's not anywhere near what I was eating before. So
And you drop it down to like a trimmed ribeye or even leaner than that.
yeah, even leaner than that, it's like sirloin and
So like a trimmed sirloin.
well, I mean, sirloin generally doesn't have a lot of fat in it. I
So
mean,
that comes out to like 40% fat roughly. Is
I
that
think it's
where you're?
30 to 40%, something like that. Yeah, pretty
Yeah.
lean. That's pretty
Man, you're
lean.
looking great, man. You're looking great. I'm jealous. I see your workouts, man. You're looking good.
Well, I'm just, like I said, I'll probably reverse. I was going to do this stuff for CrossFit, but I don't know, man. I don't know if CrossFit's even going to happen anymore. I don't know if you guys have been paying attention to the news there, but that's just blown up. So I may just kind of put a little bit back. I probably lost more weight than I wanted to be honest. So
Yeah. Yeah.
anyway, well,
What'd you drop? Like 10 pounds? Sorry. I'm
no,
like,
more like 20 pounds.
20 pounds.
Yeah,
Wow.
yeah. So that's more
Holy
like up on
crap.
the scale. I was like, well, I'm a little lighter, so I'm going to put some weight back on. So
Yeah.
let me just introduce Tro. Can you do me a favor and tell folks about you, because you got a great story, and then because there's a few people that might not know what your background is, and then we can get into some questions.
Yeah. Yeah, sure. So, you want the 1 hour convo or like the 2-minute convo?
Give us a 2 to 3 minute combo. Yeah, that's
Okay. So I'm a board certified internist, and about 5 or 6 years ago, I found myself at 350 pounds. So 6 years ago now, 350 pounds, asking myself, how did this happen? And then I started to go back to the medical literature, just like you did, Sean, and kind of see, all right, let's approach this, how they trained me to, as an evidence-based doctor, right? I scored on the 90th percentile on my internal medicine board exam. I trained in the Yale system for internal medicine. And there I looked at the head-to-head studies, and I found low carb did better than low fat. I'm like, well, wait a second. All my med school notes, all my training, it said low fat is the way to go. Eat lean meat, eat, whole grains, eat a bunch of fruit. And so I started going slowly down the lower carb, lowering my carbs, and got great results. Read thousands of papers to confirm the stuff I found, and then read hundreds of books to confirm what I found. And the answers are right there. Lowering your carbohydrate is absolutely probably the most viable way to lose weight for the majority. And that's what I did. And I was immensely successful. Ended up losing 100 pounds. Always loved exercise. So always exercised. But it wasn't until I cleaned up the diet that I really got the weight to budge down. And everything felt better. Everything felt better. And then, I'm online. I'm seeing you, Sean, doing what you're doing, and I'm like, who is this? Who is this doctor? What is he doing with the Carnivore? And I kind of saw you progress through that. And I remember interacting with you, being very critical and skeptical early on, saying, what is this guy doing? There's no way you can just eat meat. What about vitamin C? And I remember it was like, I don't know, 3 or 4 or 5, maybe 5 years ago or 4 years ago, where you said, Tro, why don't you just drop it to no carb, right? And see what happens. And I was like, all right, fine, game on. So I did my first, maybe it was, I want to say it's 3.5 or 4 years ago. I don't know. I said, all right, I'll go from low carb to no carb. And I did a month of no carb. And it was miserable in the gym. I remember, I was in the gym working out. I was lightheaded. I felt terrible. And you're like, no, just stick with it. I'm like, I'm constipated. You're like, just stick with it. It's funny. And I did it for a month. And like, maybe I introduced dairy after that. But I noticed about 4 weeks in, my wife's like, Tro, you lost a lot of weight. You're not feeling so good. Let me make you some food. And I remember my wife made for me a pound of bacon and like 10 eggs or something like that. And I was too lean before that. I was eating way too lean, probably like, maybe 20 or 30% fat. I didn't feel so great. And then the minute I increased the salt and the fat, I remember the next day I was in the gym. It was like, it was light in day. So I gave my body time to adapt to really being very low carb, maybe like 50 grams to 0 grams, right? And I increased my salt, increased my fat. I really think those two things started to happen. So I didn't continue carnivore, after that first month. I re-experimented maybe 2 or 3 months later, going to near 0 carb. But I definitely, something happened in that month. I remember it 3 or 4 years ago, and it pushed me to really appreciate the very low carb approach, particularly to athletics. And then I went on to run, I lost 150 pounds total. I went on to run a 5K. I went from running 1 mile in like 18 minutes to running my town 5K and placing first for my age group. I ran 5K in 19 minutes, completely no carb, fasted all day. So definitely appreciating that fat can be used for athletics after losing the weight. So that's kind of my story. And everything they taught me was wrong. Everything they taught us, Sean, was wrong. And we really have to reevaluate things. And you challenged me along the way to reevaluate things. And let me tell you, there's months on end that I go carnivore now. I love vegetables and low carb fruit, and I'm a food addict, so dark chocolate will always find its way into my diet somehow. But I go months at a time, basically meat, and just enough vegetables sometimes to make my wife and cardiologist happy.
Yeah, and I'm familiar with the story. Obviously, it's a good story. Tro, hey, just one minor. I'm getting asked for a technical thing. If they're saying you're in the frame on the very far side, I don't know if you can rotate your.
How's that? That's good.
I guess that's better. Yeah, I guess I don't know who's telling me that, but that's cool.
How's that? That's good.
That's good. Hey, let me ask you, because this is. I mean, there is. I want to see your thoughts on diabetes, because this is something that I think there's just this huge back and forth on. Low carb carnivore diets, ketogenic diets. There's people saying that, particularly high fat diets, lead to insulin resistance via ectopic fat, but liver fat, intramuscular myocyte, fat deposits. What are your thoughts on that? I mean, how do we?
Oh man, don't make me get mad. Are you trying to trigger me, right?
No, I just want to know, because I think there's a lot of, I mean, you listen to the folks on the low fat side or the plant-based side, and they say it's all about, fat causes insulin resistance via these mechanisms. And it doesn't really matter what your blood glucose is, because you're still insulin resistant and you'll fail a oral glucose tolerance test, and therefore you become carb intolerant and thus, you're insulin resistant. So how do we sort of rectify that situation?
Yeah. So, well, let's take it a step further I'm going to segue into so the story becomes, all right, then 3 or 4 years ago, I'm like, I can't keep practicing this way. And then I go down the rabbit hole of becoming obesity medicine certified. And then thinking to myself, when I'm starting this practice, how could I make weight loss and diabetes reversal easy? So since, the last 3 or 4 years, we've been 3 years really here, 2 years, we've been in this physical office. 3 years, I've been doing virtual medicine. We have people on remote scales, remote blood pressure cuffs, remote CGMs. This is how I'm going to segue. I have yet to see a case of a person develop worsening diabetes eating lots of meat. So pragmatically speaking, I have not seen somebody, develop worsening diabetes on a mostly meat diet. Okay. Now the question is are we taking away the constant glycemic excursions of eating carbohydrates? What's going on to that baseline sugar, right? I mean, is that what you're kind of asking? Like, what's the difference here? Let's put it this way. I have yet to see somebody's liver fat. We measure bioimpedance. We're measuring people's body fat on remote scales, over 500 people on remote scales. Body fat percentage has not gone up. We have people that are measuring, we have an 8-point body composition scale in our office. We have not seen visceral fat go up. We have not seen anybody's CGM worsen. So I don't see any evidence besides the epidemiologic data to support the idea that increasing fat or increasing protein and fat will cause or worsen diabetes. So I mean, yeah, your body will be able to make glucose out of fat and protein more efficiently. That's true, but I don't believe that's the underlying pathology of diabetes. I believe the underlying pathology of diabetes is being high, over fat, basically, okay, and being intolerant to carbohydrate. So if you can leverage somebody's non-hunger, make them not hungry, and have them lose weight eating predominantly meat, this is like two separate issues. Insulin resistance is the insulin resistance seen in anorexic is not the same insulin resistance you see in somebody who's over fat, right? And their fat cells are literally, overfilled. It's not the same exact disease state. So, and the problem is the way they got to say that, the low fat community got to say that, is because they're looking at epidemiologic data and saying, if you eat more meat, you get more diabetes. Well, if you eat more of anything, you get more diabetes, so I don't think it's, and they've debunked this. They've looked at the case. If you talk to, Ben Bickman about ceramides, he's talked a lot about how that's even not necessarily true. That, they like to say that it embeds into the pancreas some way. Well, we have, we've pretty much seen in 6 days you can get rid of liver fat on a low carb approach, calorie controlled, right? So it's a bunch of, I don't want to say BS, but it's just, there's a big difference between the epidemiologic signal, the big data signals, and what we actually see in interventional studies, right? There's a big difference. And so I think that's why maybe the low fat community can't reconcile this. I don't know. Does that answer the question?
No, I see a lot of the epidemiology where the associational data is always skewed, and we know the limitations with that. I think you clued me into this maybe a year ago, that Kevin Hall was going to do that study, and he did the little, I think it was considered a pilot study. Still, I don't know if it was or went out in preprint, and I'm sure you're aware of it.
Yeah.
And I think one of the findings in the sort of the ketogenic arm was, if I'm not mistaken, was a reduction in liver fat. If I'm not mistaken, was that part? Did you remember that part of that study?
Yeah. So his most recent study, yes, there was a decrease in liver fat, despite eating more calories, and there was more weight loss despite eating more calories. So, clearly there's things we don't understand that's going on. And look, calorie for calorie, we've done now. There was a great study just done, that a low calorie approach doesn't add anything to the endothelial benefit of going low carb, right? Calorie for calorie, if you replace fructose, you lower your liver fat, right? So calorie for calorie, low carb reduces metabolic syndrome, right? So we know these things, and they're in the literature. You just have to dig through and kind of piece it all together. And because this data is in contrast to, I want to be generous to the low fat community and the plant-based community, because I think they can't reconcile this data. Maybe that they have the opinions they have, but look, we've had over 500 patients on remote scales, remote CGMs. We've yet to see anybody get worsening insulin resistance with a high meat diet.
Now, are these people that you're seeing primarily starting out clinically obese? This is the group you're looking at, because you mentioned starvation or anorexic diabetes. And there is something called starvation diabetes. What are the different people you're seeing?
Yeah, no, so the reason why I brought that up is if you look at the literature on fasting, long-term fasts, you get insulin resistance, longer term, right? Like medically supervised long-term fast. If you look at anorexics, they develop insulin resistance because you're forcing your body to use protein and fat for fuel, but it's a different problem than the average diabetic. In our clinic, we have two types of patients. Majority come here wanting to lose weight, right? Weight loss. Like you have the guy that lost 150 pounds. Of course, they're going to go to him to, help losing weight. But then we have a subset of patients, actually probably referred from your group, either the MeatRx or the Facebook group, who come in wanting to maintain a high fat diet, but they have, some extreme lab abnormalities, and they're trying to figure out what the best approach is. So those are the two subsets. So we have like the worried well, I call them, people who are like lost weight, done amazing. They just want to make sure that, the labs check out, the people who need that intellectual support. And then we have, I'd say overwhelming majority want to lose weight and reverse their diabetes. We have like the rare, people looking for like help with autoimmune stuff. That's not a super focus on in the clinic, Does that make sense? Sorry, what was the second question?
No, I think you pointed out the two different sort of subsets of people. I mean, there are some people that have, I guess, autoimmune diabetes, whether it's type 1 or type 1.5 or MODY or something like that. Do you deal much with those types of folks? And
we see them. We discover them because we're testing insulin, we're testing C-peptide. We're trying to figure that out. We discover them, but again, it's I'd say overall low prevalence. Really, it's mostly type 2 obesity. That's the people coming to see me.
Yeah. Okay.
Yeah.
And then, what are your thoughts on fasting? Tro, are you a big fan of fasting or intermittent fasting?
Yeah,
or
I love not being hungry and then not eating. I love it. So what do you mean by fasting?
I think that's an important distinction. We have this sort of physiologic fasting that occurs when you're not hungry and you just don't eat. Well, I think that's what happens a lot of times when people go on ketogenic or carnivorous diets, particularly when they eat enough fat. And the other one would be, you've got a prescribed time, and you eat whether you're hungry. You may still fast even if you're hungry. And this would be some people that, they write down a schedule, and sometimes it's 2, 3, 4, 5, 6 days a week.
Yeah. So the way we approach it, I'm going to tell you how we approach it, and it's very super easy. We first push down carbohydrate. Okay. And once carbohydrates are pushed down, then we push down meal frequency, meaning you can go down to like 1 meal a day, right? After that, the question becomes, well, what do you do next? Now, one of the approaches that you've mentioned is lowering added fat. That's something you've done. Another approach that we consider is adding exercise, right? And another approach is extended fasts. I generally prefer somebody add exercise, consider fat moderation, and then if needed, add extended fast. But we have people who are immobile, for example, they can't exercise for whatever reason. And we have people who, look, they're immobile and they can't really reduce their, daily caloric intake, much less than 1,000 calories a day, maybe they're petite, maybe they have just a low RMR, don't get a lot of activity, older, right? So very rarely do we promote extended fasts, but let's say 10%. 10%. And if we do support extended fast, which we do, we treat it like a drug. You do one 48-hour fast a week. If that you don't get the desired result, then you add a second 48-hour fast a week. And then ultimately, when you can be more active, you add in activity and dial back the fasting. So we try to use fasting appropriately. We've had people go up to 3 48-hour fasts a week. So that's kind of our approach. We leverage it like a drug. You need more than one 48-hour fast a week, then we add a second one. You need more than a second one, then we add a third one. But ultimately, we try to get people to increase their activity. And when you do that, we find that it's better to probably, focus on time restriction and not extended fasts. Does that answer it's a little nuanced answer. I don't know if that helps answer it.
No, it does. It absolutely does. Let me see.
Yeah, we're not so big on like the 5-day fasts. I mean, if somebody wants to do like a 3-day fast once a month, or like a 3-day fast once a quarter or something like that, that's not, we don't discourage that. Obviously we'll encourage salt and electrolyte intake.
Somebody's asking about, and these questions always come up, these poor perimenopausal women who are always sort of feeling like they're getting, they're having trouble. What do you find, how do you deal with that? That's a subset of the population. It seems like women that when they go through menopause, they get into this where they hold more fat and it's frustrating, and they have hormone issues. Does that have anything that you found that impacts that positively?
Let me tell you, this is like this is half of my practice. So they have it the worst. Postmenopausal women or perimenopausal women have it the worst because one, they're typically more petite, right? They're than a male counterpart. Okay, so they're typically more petite. Okay, where they were 30 years ago with more estrogen and testosterone was a higher resting metabolic rate. Okay, where they were 30 years ago with their overall, metabolic rate outside of hormones, right, was higher. So between the age 18 and 50, your metabolic rate decreases by about 200 calories per day or 300 calories per day, right? And then you go through menopause and you see an immediate, 25 to 50 calorie per day decrease due to the hormonal changes. So they have it, and they're probably, I just anecdotally speaking, they're more likely to have done yo-yo dieting, right? So they're more likely to have done yo-yo dieting. So Kevin Hall actually showed that it's a great way to lower your resting metabolic rate and decrease your, energy expenditure. So they are the hardest to lose weight in our opinion. If you add in. And so that's one of the factors we've noticed are a predictor of slow weight loss. Other factors that we've seen that will slow weight loss is mental health issues. Any mental health issue, right? And again, what happens when you go through perimenopause? Your sleep quality goes way down. Okay, you get hot flashes, your sleep quality goes way down, and your sleep amount goes way down. Right. So, and with that, depression increases. Okay. If there's no hormonal effect, just from the sleep deprivation itself, the mood can change. So, sleep is, and we know that sleep deprivation increases insulin resistance. We know it increases sweet cravings, food cravings, right? So it is like a ticking time bomb. Being perimenopausal or postmenopausal, it's a stress test for weight gain. So this is the highest, they have a lot of that group. It's very difficult. And we make it very clear to them, this is what you're going to face. Right. And it's not just a calories approach, right? Because I can't lower your metabolism so slow. It's like 1,200 calories. You can't lower it much more than that. Right. So we have to work on sleep. We have to work on non-hunger. We have to work on added fat, and we have to work on exercise. Right. So we change the focus a little bit. When I get like the 30-year-old truck driver who's eating like all sorts of, processed food, like they're easy. All I got to do is get them to stop drinking soda and they're going to lose weight. Right. But that age group, I think, as you pointed out, it's a multimodal approach. And the key is longevity. What are the changes you can make over time that are easy that you can do for a long time? So it becomes more of a behavioral and multimodal approach for that age group. Because it's like, hey, look, you're not going to see the, 10 pounds of weight loss you did with the juice fast 10 years ago, right? It's, can you get to sleep 1 hour earlier? Can you improve the sleep quality? Can you reduce the added fats just enough? Can you time restrict just enough that you feel good and you're able to lose weight? And how long can you maintain that? So I think the longevity and the behavioral components become a lot better, and the outlook, framing it like, hey, look, if you skip one meal a day, your meals are so small. If you skip one meal a day, we're talking about 400 calories. Even if you do that every day for a month, you may not even see a pound of weight loss due to water weight fluctuations, right? You may not even experience that. So you may have to, go one meal a day or a small narrow eating window for months before you experience anything, right? Or see anything on the scale. So that's why I think intellectual support and behavioral support becomes a huge issue in that population.
Yeah, there's a comment in here that says some of the women find that they've actually done better going higher fat. Any thought as to why that might be?
I think it has to do with ketonemia. the hyperketonemia. You know, I think that, and it could be hormonal too, right? It could be hormonal too. So I think ultimately it's what works. We see about 1/5 to 4/5 benefiting from higher fat. Sometimes people go higher fat and their hormonal and their satiety kicks into the point where they're able to eat less frequently, their mood stable, better sleep, and then they do better. It's about 1/5, whereas 4/5 probably do better, you know, and this is a rough estimate, maybe 1/3 to 2/3, maybe somewhere. That's my just like off the top of my head approach doing higher protein versus higher fat. You know, the other end I see is people say, okay, I'm going to cut the mascarpone, you know, I'm going to cut the, you know, the cheese and the, you know, cut the nuts, and then the mascarpone and the sour cream comes in, right? And so that there's two dynamics. There's other people I've seen, they go really high animal fat, they get full, they don't eat for a day, sometimes 2 days. So, you know, I think the sleep improves a little bit. I think it's individual.
You maybe kind of alluded to this. Do you find a difference between dairy fats and other animal fats as far as
Yeah.
issues?
Dairy fat is crack. Dairy fat is crack. You know, for the longest time, I didn't know why I don't like cheese. I love cheese. I love it. Love whipped cream. Love heavy cream. Love it all. Love butter. Right. But the problem is it was made for an animal. It's zoophory, right? It is designed to have an animal keep eating, right? Dairy is literally designed for a small mammal to keep eating. And I couldn't, because the macronutrients look great for cheese. Very low carb, you know, good fats, high in protein. And I'm just thinking to myself, what is it about this that I don't like? And I was thinking about it, you know, same thing with fruits. I like fruit. I enjoy fruit, you know, but they're just designed to have an animal keep eating, right? Same with nuts. And the same thing with dairy. That's another thing I think that's why I don't like dairy. If you look at the epidemiologic data, dairy fat is associated with good outcomes. Full fat yogurt associated with good outcomes, right? I love, but I got to be honest with you. I don't like it because it makes me want to keep eating. I'll do anything not to be hungry. So, is that, you know, well, let's put it this way. To get shredded, how much cheese did you eat, Sean? Yeah. Right.
Yeah,
When you want to be happy with your diet, though,
yeah.
you use cheese. So just learn, like, you feel good. You like the amount, you like the food you're eating, right? And you're happy with your diet when that dairy fat is high. It's associated with good outcomes in health outcomes in the epidemiologic data. I don't know that that matters to me, but maybe it matters to you. But I don't like it because it makes me want to keep eating. And that doesn't mean don't eat it. I'm just telling you why I don't like it. I still eat it, you know. I'm telling you why I don't like it.
Yeah, fair enough. And what are your thoughts on some people commenting on, again, it's back to kind of diabetic stuff, but higher protein leading to higher blood glucose relative to higher fat?
Yeah, it's a very rare phenomenon to see that happen. Usually when you go higher protein, you get leaner. I got to tell you the exceptions. So the exceptions are the insulinopenic people, typically older, or they have one of the things you talked about, LADA, or, you know what I mean? These people that just don't make type 1.5 diabetes, where they just don't make enough insulin. We see it. We see their glucose go up on the CGMs. So I think like less than 10% of people have to worry about it. And ultimately they could just N=1 and figure out what works for them. Most people don't have to worry about it, about protein intake. But if you're type 1, you'll see it, you know, 5 to 8 hours later, if you go high protein, meaning if you have no insulin, right? And your pancreas is unable to make insulin, you'll see it hour 5 to 8, your blood sugar will go up. Sometimes even 12 hours later, your blood sugar is going up. So it'll make your blood sugar go up, but I don't think it's not the same, you know, it's not the same as a carbohydrate excursion. It's usually like nice, slow little ramp up, and then it comes back down. So we treat it differently than carbohydrate excursions, but it's not something most people have to worry about. So unless you're, type 1.5.
What do you think about the concept of metabolic flexibility in general, in people that, like there's people that are just thriving, going to a ketogenic diet for, often years and years, and some people would criticize and say, well, you're not metabolically flexible. What is your thought on that, on maintaining that by periodically taking in carbohydrates or that type of thought?
I've thought a lot about that. Like, can you get a neuropeptide YY resistance or CCK resistance, or, can you get resistance to this diet? I mean, we just don't know, right? We just don't know. And if you look at nature in general, there's a yearly carb refeed. The animals, the bears that are usually eating salmon, they get the fruits and the berries that, drop. So I don't know the answer, and that's a long-term health question. We don't know the answer. So I think, that as long as you know that we don't know, and you treat your diet like a clinical trial, I'm taking the ultrasound machine and putting it on my carotid. I'm measuring it. I have a lipid machine right here, right? I'm measuring my own lipids, right? So I'm treating this like a clinical trial because it's my life. And I don't know the long-term outcomes. We don't know. I just try to do the best I can. Right. So I think there's some, there's definitely some veracity to that idea that, hey, maybe you should, if you can imagine, if you're a carb oxidizer, to say, hey, maybe you should be metabolically flexible and burn fats for fuel. If you're burning fat for fuel for 5 years, which is where I've been, and I know, Sean, you're just about there. We're both kind of the same frequency here. I'm sure you've thought about it, like, is there any merit to this? At the least from an intellectual curiosity perspective. So, I mean, I have enough carbs. Like, I have a food addict. So nuts will creep in, berries will creep in, so I think I get enough that I'm exposed to it, I don't see the need to, like, go super high carb, if that's what you mean. I don't think I've taken more than 100 grams of carbs in 6 years. Let's put it that way.
Yeah, I think some of the critics will say that, if you're on a long-term low carb diet, then if we challenge you with a glucose load, then you're going to fail it. You're going to have these huge glucose excursions. But I guess the other thing,
not if you periodize carbs for like 5 days.
Right. But the other thing,
and then,
but I mean, the counter to that would be like, I would say, well, if you're on a low fat diet for years and years, and then I give you a fat challenge, you're probably going to have this huge triglyceride excursion, which is probably going to be higher than what you would see in a person who's fat adapted. Perhaps, I don't know. I don't know if that happens or not. Maybe it does.
No, I mean, we know that because look at the triglyceride, look at the fasting triglycerides of low carb diets. They're always lower. I mean, so we know they will become lipemic, right?
Yeah, but that's not the postprandial. I'm talking about postprandial challenge.
Yeah, postprandial. Yeah, their fat oxidation is lower. We know they will. We know. I mean, and Kevin Hall showed that with the mixed meal test, right? Is that the postprandial, your area under the curve will be lower for fats, right? For blood fats. I think that's pretty clear in the literature, from my opinion.
Yeah, I mean, it sounds like it's just kind of basically this Randall cycle type of stuff where you're using one or the other, and you're not mixed. You can't mix them very well. When you use one, you're not as good as using the other type of thing. So it hangs around more, perhaps. So,
I mean, look, we have a paper coming out on low carb and intermittent fasting, dropping fasting triglycerides from 1,000 to under 200. Using a high fat approach.
Yeah, we see that all the time. I think it's carbs are driving the triglycerides. Hey, let me ask you, because you mentioned your carotid, you have a little Doppler or a little Doppler machine. You can do your own. Are you doing that much with patients? Are you seeing patients and doing their carotids?
Yeah, before Corona, we were regularly doing carotids, and in fact, well, yeah, absolutely. We do it on anybody doing a long-term ketogenic diet. We give them a baseline, and then, later on we'll reevaluate that, I think. And we also highly recommend CAC scores. So, again, we treat it like a clinical trial, right? So we don't know the long-term outcomes. Let's measure the long-term outcomes. And there's been a couple of cases where a CAC score or carotid has worsened, right? It's very rare, but they've worsened. And we've, dialed back. We've actually prescribed carbohydrates. The Low Carb MD podcast host has prescribed carbohydrates. So, and we've seen LDLs come down from 700 back down to 150 with carbohydrate periodization, right? So if you understand the mechanism, or increasing meal frequency or increasing weight, right? There's great ways to lower LDL. And we very rarely do for modestly elevated LDL, but we've had a case, which we will also publish, of a LDL that went up to 700 with a worsening carotid and a worsening calcium score and cholesterol deposition in the tendons and, xanthomas in the eyes. And we have periodized carbohydrate. They were told to take an injectable medication, but we just simply periodized carbohydrate to exercise and lowered the LDL from, 700 range to under about 200, I think is where that particular patient is at, but it'll probably go lower.
And when you say periodized carb, how did you do that? What was it? How frequently was it?
Yeah, I mean, this guy had a 6-pack. So, the guy basically, I don't think you could tell, if you cut off at the head, I don't think you could tell the difference between you and him, right? So very lean. And so before exercise, we would periodize fructose to exercise, and then we would do a small feed of starch at night. So still under 100 grams of carbs, right? But probably in and out of ketosis, still felt good, but enough to lower the carbohydrate. Enough to lower the LDL.
That's it. And the fat content, was that, I guess that would be reduced slightly as well, or still pretty much high fat?
Still pretty much high fat.
Interesting.
It's not, I don't think it's modulated by fat at all. I think it has to do with, maybe slightly, but probably has more to do with just energy availability, right? Carbohydrate energy availability. And, right. And his fat mass is so low. I mean, think about this caloric output from fat. It's got to be pretty low. So we theorize that if we increased carbohydrate and carbohydrate frequency, or if he gained fat, he'd probably lower the LDL, which was the case. When he started, his LDL was lower. But then as he got incredibly lean, that LDL went very high. So just periodizing carbohydrate was enough for him to, more than drop his LDL by hundreds of points. We wouldn't have done it if he didn't have worsening CAC and worsening CIMT. We probably wouldn't have done it, but it ended up with his end organ dysfunction, right? So I think you have to. Yeah, that's rare. Most people don't get to 700, and most people don't have those issues. They get the calcium score, repeat calcium, and even with like a, higher LDL, for some reason, he didn't see that endpoint. So again, harps on, treat it like a clinical trial, right? Treat it like a clinical trial. You need that we all need that. I need that intellectual support, Yeah,
I'm just wondering where how you came to the decision to periodize carbs in that situation that would lower the LDL. That's interesting. But
we knew from before. So for that particular case, we knew that his LDL was lower. He didn't come. So he came to me having been on a ketogenic diet, very strict near carnivore diet for years. He watched his LDL go from near about normal, 150 range to 700, like in measurable, basically, is where it went. And then he came to me saying, "What do I do?" And I said, "Well, let's measure everything to see if you have any issue depositing that cholesterol anywhere." He had xanthomas that were new, and we've had actually two very similar cases of this case. One which we lost to follow up, another one which we're publishing alongside this case. So and we repeated a CAC. He had one done like 6 years prior, and we repeated a carotid. She had one done 4 years prior or 5 years prior. And so we were able to compare where he was in those 4 or 5 years. And given the deposition of plaque, we said whatever's going on in your body is enough information for me to say, hey, why are we going to hang out at a LDL 700? So, and it didn't take much to lower him, just like I said, maybe 50 to 100 grams of carbs a day.
Yeah, and you mentioned fructose. Did you get that from fruit, honey, or how did you?
Yeah. Fruit. This is berries.
Yeah.
Berries. Yeah, berries before exercise. Enough to basically be utilized by the liver during activity, and then some starch at night. So out of like 600, maybe there's like I've prescribed carbs in 5 cases, but those are the interesting ones, right?
I know there's some talk around people. I mean, certainly we see a lot of people with relatively low coronary artery calcium scans, often zero, that have been on high fat diets for many years. Have you seen the phenomenon of it actually reversing? Has that been something that's crossed your path yet? I know there's some people that have mentioned that they've seen that, but
we haven't really worked extensively to reverse it. So there's a talk of K2 and D3. Right. But if you look at the data, it seems like exercise increases CAC, age increases CAC. Statin use increases CAC, maybe protects against heart attack. I mean, it's just, I don't know what to make of that. I don't know, even the serial monitoring of CAC, we've done it, but what is exactly the utility? I'm not sure. Makes sense to me theoretically, but again, all this is like the Wild West, right? Treat your life like a clinical trial. Nobody really knows, right? So, if somebody has a high CAC, we determine that they're high risk. We're probably more likely to recommend pharmacotherapy. Very rarely do we recommend pharmacotherapy. We explain why at a high CAC, you may want to consider it on top of lifestyle interventions. So it's just, this is all interesting, right? But again, it's like, look, at the end of the day, what do you do, right? And that's a tough question to answer. Luckily, we have a really smart doctor here who probably tell us what to do, or another one I see lurking around here.
Oh, Phil Avadi,
Yeah.
I don't know. Phil, let me unmute Phil and see if he wants to drop a comment in here real quick. Phil, are you on to put a comment in on that, or did you hear?
Just repeat that again. Sorry, I was multitasking here.
Yeah, we were just talking about what exactly, lower reversing CAC, and does it lower a risk factor or not? I don't see any harm in taking D3 and K2, but it's like so much we don't know with watching CACs. So I figured it's more up your wheelhouse than my wheelhouse.
Yeah, exactly. I would agree with that. I think we don't really know the answer for sure. The data on reversing CAC, high CAC scores, vitamin K2 and D3 and low carb and all that, but we really don't have any data long term what that means for your ultimate risk of a cardiac event. Like all the blood work, the CAC scan, although I certainly favor it over blood work because it's a more direct measurement, it's still just a risk score. And we know, for instance, that people with a CAC of 0, still have a low but not 0 risk of cardiac events. It's about 1% over 10 years after a CAC score of 0. And even with very high CAC scores, it's still just relative risk we're talking about. There's nothing that we have in our armamentarium currently to truly predict cardiac events. We're all just talking about relative risks.
Yeah, let me just, because you made a comment that's upset a few people, or they were concerned the fact that you said that exercise increases the frequency of coronary artery calcium. What is a mechanism by which that is? That actually protective? Can calcification be protective? Or
the same way that a statin increases CAC. So, mechanistically, meaning interventionally, we know that a statin increases CAC, meaning like we give you statin, we measure it, or you're more likely to take a statin, you're more likely to have an increased CAC. So we know that. There's been studies where they've, it's again, association data, but it makes mechanistic sense to me. You know, exercise doesn't necessarily remove the dental carie in your tooth that's causing chronic inflammation, or the chronic hyperinsulinemia that's causing inflammation, right? So exercise may mitigate the weight component of that issue, but it may not reduce that. Like if you have autoimmune disease, right, like Kawasaki or something, and you have scarring of the arteries of the heart, right? Exercising is not going to reduce, it will remove that insult, right? So in fact, it may increase the flow through that insult. So you may see a higher CAC. And we see that concept play out in the association data, where the more you exercise, the higher your CAC is, right? So does it mean your risk is absolutely higher? Does it mean, do I tell my patients who have a high CAC not to exercise? No. I just tell them, look, there's a lot about CAC we don't know. Is it healing, or is it injury, or is it both? I don't really know. We don't really know. Maybe somebody knows that's an expert on maybe we've got a couple of, cardiologists who specialize in cardiac imaging. But, you know, my last conversations with those experts like Phil and others is that we don't really know if it's injury, repair, or both. And it would probably behoove you to assume that it's both injury and repair. So I hope that clarifies it. I haven't measured my calcium score, but I have it scheduled. If I had a high calcium score, I would be even more, eager to exercise. And I'll tell you why. If you look at the Maasai, right? The Maasai who ate mainly meat, right? As far as I know, there was a study on that autopsied their hearts, right? And Sean, you probably know about this and wrote about it, right? What did they find in their hearts, right? There was more plaque, right? But these vessels were large and pliable, right? They were large and pliable. So I think that exercise probably plays a role in making sure that that vessel is flexible and not stiff. And I don't know if I'm interpreting it the way you would, but that's the way I interpreted that. So I don't know. Tell me if I'm wrong.
Well, I don't think we know. I mean, yeah, but I mean, that clearly that vascular dilatation I guess it's theorized why it was protected from them actually having cardiovascular events, which is, again, at the end of the day, what we're all trying to avoid is the actual disease itself, where we have the clinical outcome we don't want to see. So let me shift to, because we got a little bit left here, Tro. I want to ask you, because your practice has taken on a radical change. When I met you, I don't think you're still not. Are you still doing the hospitalist role, or are you completely divorced from that?
I took off for 3 months, and I'm back in a very small role. Very like less than part-time role. I'm full-time here. I'm basically, we have like a couple month waiting list, really, to get in to my office here.
And like I said, and Phil is taking up locums and doing some similar sort of remote type stuff. What has been the difference in your quality of, I don't know, quality of life or fulfillment doing what you're doing now versus standard hospital care type stuff?
Yeah, I mean, it's like, let me tell you, I'm actually making a difference. I'm actually making a difference in people's lives. Stepping outside of that insurance model, and we may enter the insurance model kind of like Berta did, but stepping outside of that insurance model gave me the time and the flexibility. I mean, look at the things we do here. We have remote scales, remote blood pressure cuffs, water weight we could track remotely, body weight, body fat. We could track CGMs. We can send people ambulatory blood pressure cuffs in the mail and get it back, retrieve the data, do sleep studies virtually. We can send people out Holter monitors. I mean, we did this not because of COVID. We did this 3 years ago because we wanted to be better than everybody, more convenient, more easy to help people like me who struggled with weight to make weight loss easy, right? Not like come back, see me in 3 months, you know, for a refill, or, you know, I'm not going to give you a refill. You have to come back into the office. Why the hell do I need to do that? I have a blood pressure cuff right now. I see your readings in real time. There's no need for you to come back. We're going to make it easy. We're going to make medicine easy. And why wouldn't I want that data, right? You're stepping on the scale every morning. Why would I wait for you to gain 20 pounds in a year when I can see it in real time and call you when it's 6 pounds, right? And we're beginning to, so not only, so we're actually having an impact on people, and we're measuring the impact we have. You know, that's the other thing. We're able to see how good we're doing across our entire patient pool, right? And we saw with COVID what happened, right? We saw with COVID, all the scales started to go up. First, it was the water weight. Then it was the fat mass. And immediately we started getting calls. Can I get anxiolytics? I'm binge drinking. I'm binge eating, right? So we said, all right, you know what? Instead of seeing, you know, one person at a time, we're going to see all 100 of you, 500 of you. Come. Right? We started getting 100 people a week coming to like these town halls we're doing, just like this, right? Just like a community like this. And immediately we see that impact on the scales go the other way. So we know we're having a good, so I think, let me tell you, I've never been more enthusiastic. Now we have 2 health coaches. We're considering hiring another doctor. We've helped Brian get set up, Brian Lenskis, and we helped Andy Fung get set up. We have 2 other doctors we're helping get set up. So doing the same model, because we need it, you know, we need it. So I don't know, is that answer? So I'm inspired. I'm re-inspired. We take people off meds all the time, but then, you know, here's the other side. We see, you know, we get a lot of criticism. They lose 50 pounds and go back to the doctor. It's like, oh, you're seeing that crazy guy, you know, who caused you to lose 50 pounds and get you off insulin, right? So there's a lot of other side of things that we're getting. And because, you know, we're very prolific, I guess, on social media, we have a social media presence. You probably see this more than anybody. There's a lot of backlash that comes with that. You know, having a podcast that has whatever 2 million downloads, right? There's a backlash that comes with that. So, but it's awesome to affect people, you know?
I mean, I guess if there's any good that comes out of this pandemic, is that I think they've sort of opened up the online. It made it easier for physicians. I know they rolled back some regulations to where it became a little, I think, made it a little easier for you to practice across state lines. Have you seen any benefit to that? And do you think that's going to be a permanent thing?
I don't see how they're going to. So those are all based on, just to let you know, we're licensed in New York, New Jersey, Connecticut, Texas. We have Maine, Massachusetts, and Pennsylvania within probably the month we're going to have. We have for full licensing, which means we could be your doctor in any one of those states. But then we have about 25 emergency licenses, which we've applied for, each with the state medical boards. So, but once the state of emergencies go away in those states, those licenses will probably be revoked now, or somehow limited. The problem we're going to face is, what the hell do I do? I was just caring for you, right? And you're over there in Missouri, right? Like, how can they safely, you know, make that transition? I don't know how that's going to work out. So I think that, pragmatically speaking, it's only going to get more open, right? But the problem is people don't know the state boards. It's like a big cluster. I have to get licensed in each state, guys, right? Let's say one of you guys sees me and wants to be my patient. If you're in, I don't know, Florida, we don't even touch, because their telemedicine laws are so strict, right? California is also similar to that. Yeah, I think the future is in telemedicine. If you're stepping on your scale, why don't I want that info? I should want that info, and I should act on that info. If you're stepping on, you know, if you have a blood glucose meter, it should link with me, right? So these state laws are a barrier to care. And yeah, we're busier than ever. Every doctor's calling us, how are you doing what you're doing? You know, they're asking us that. So I don't know what's going to happen with it, but it's still a challenge. You know, Illinois, for example, we applied for an emergency license. They said, if you're not working in the Department of Health, we're not going to give it to you. right? So I think it's a little bit of a problem, but we'll get the licenses. We'll get the licenses. They're expensive. People don't realize that they're about $1,000 each state, right? So yeah, I don't know. Is it too much of an answer? Probably.
No, I think it's fair to see what the state of the thing is. What else? We got a few more minutes. Anything else you wanna comment on, Tro?
No, I'm just happy to be here. And look, I think a lot of the stuff you're doing, I know you're working with David Ludwig to cohort some patients. That looks really interesting. I'm excited for you, man. And maybe we can find ways to work together. You're clearly helping so many people, and you see the value of helping, a big group of people at once. And we also see that value. And I think you're doing great work, and what you've been through personally and professionally, man. I just got a lot of respect for you.
Well, it's, life keeps throwing you curveballs, and you just got to kind of deal with them.
Yeah.
It's kind of funny. It seems like it never ends, but anyway, you just keep pressing on. Well, thanks for what you do. I mean, you've been a very, anybody's watched you on social media, and I've kind of taken a bit of entertainment in watching you kind of be very, very aggressive about defending what you think works, and keep doing what you're doing. I mean, because you're definitely inspiring a lot of people. Obviously, it's polarizing, and there's people that disagree vehemently. But I mean, again, ultimately, we're going with what I assume you're doing is producing results, and I think that's what we want at the end of the day. Is results are what really matter, despite what your philosophy is. Do you find anything that I guess, I don't know, when we talk about the calories in, calories out, I know there's a lot of, you talk about calories being important, but hunger and appetite being probably the major thing. I mean, coming from someone that was formerly obese, you personally experienced that. You want to just maybe spend a minute or two talking on that concept?
Calories are useless, right? Your brain doesn't have a calorie meter for when it shuts off, right? So calories are as a metric. I mean, look, more calorie information on labels at restaurants, MyFitnessPal in everybody's pocket. That did nothing for the obesity epidemic. So calories are a real world failure. So full stop. It's a failure, right? As a approach to weight loss. So I think, well, rather than quantifying the calorie, let's just quantify what leads you to intake calories, right? So like I said, I eat the way I do because I don't ever want to be hungry. So I never have to care about a calorie or count a calorie. And that's why I eat the way I do, because I don't want to be hungry, right? And because so far, every marker of health has improved, right? So yeah, I think calories, it's a failed model. It's interesting to know. It can be helpful to quantify something if you're not that neurotic. But I think, the way we try to treat this practice is first cultivate non-hunger hormonally and behaviorally, okay, and glycemically, and then leverage that non-hunger by decreasing intake in a way that doesn't make you more hungry. So a great way to be hungry is to eat 5 to 7 small meals a day, right? It's a great way to be hungry, right? So what Atkins showed us numbers of years ago is that, look, hyperketonemia, whether it's through low carb or through time restriction, will make you not hungry. So that's the basis for which we work. We want you to be not hungry, so you don't have to count your calories. So you can just be not hungry and not eat. And then as you push your meal frequency together, right, you automatically restrict calories, right? If you ate at 1 and then you're going to eat at 5 again, you're naturally limiting your portions without even trying, right? Because that meal frequency is tightened. So why would I focus on calories when I could focus on things that actually matter? So I want to end calories. I do. I want to end them. Now you got me triggered, man. You know how to get me triggered, I think, right? So
I was looking at one of your tweets and you said take a keto carnivore diet and smash it with a whole food plants diet and put a intermittent fasting in there. And I assume you're referring to the satiety producing effect of fiber basically being the major reason for the plant-based inclusion there. Is that
I think it's you know what? Let me tell you how I use if I want to mindlessly eat, I'll do it with celery, right? So there's a benefit to that. Do I care that it's I think it's probably hydration and fiber, maybe, but maybe volume, maybe just buying me time with a low energy intake. I don't know what it is. Sometimes I could eat a head of lettuce after a meal and it buys me time, right? I mean, I don't really do that now so much, but in the beginning it was very useful. I think, fiber intake, I mean, I wouldn't eat just for fiber per se. I think, does it help you be not hungry, right? So I think that's the way to, and is it getting you your body composition results? So I think that it's definitely, I mean, look, Kevin Hall showed that if you go whole food plant-based, your caloric intake goes down. So can we leverage that in a way? Right. So I do think that there's utility. I wouldn't say it is like fiber satiating, but maybe hydration, lack of energy intake, and possibly the bulk of fiber could be leveraged.
Yeah, I've seen some people have success, and particularly when I was leaning out, I would take advantage of things like gelatins, like big giant bowls of gelatins that would make, which, had no calories in them basically, other than a few, or even just ice where you just put a little bit of flavoring there and you've got this huge amount of volume, and you can get volume a lot of ways. And there's actually, I looked at studies on water and satiety, and it does have a transient satiating effect, although again, it's going to buy you an hour or two, maybe that's enough to get through that peak ghrelin time, perhaps. I mean, that's I think that's
I think it's volume, time, and what did it replace? Like, you got to look at it. What it replace? If my celery replaces my macadamia nuts, on a baseline carnivore diet, right? I think, or like a baseline, meat heavy ketogenic diet, right? It's probably I'm going to get my body composition results. So I think it's just, if you want to be not hungry, eat real food. If you want to be even more not hungry, time restrict. If you want to be even more not hungry, distract your mind. You're not going to eat if you're running away from a bear. So go hunting for 12 hours and see how much you eat. Like, are you going to stop everything you do and go back home and make, a ribeye? Probably not. So what can you leverage? What defense can you leverage against hunger? I'm an expert in that because I got no impulse control. I've learned to adapt my diet so I don't need to use my impulse or willpower ever. I feel strongly about that. Calories doesn't do anything for that. Doesn't do anything other than leveraging your intellectual, your central planner, which is it's just a finite process, that I would not rely on.
Yeah, I think the one thing you mentioned, that exercise, acute bout of exercise seems to shut down, at least transiently, hunger as well, I think, through reductions in ghrelin levels. So I see that if I'm hungry in the morning, I'll do a workout and then I won't be hungry, and I won't be hungry for 3-4 more hours. So that's also sort of a time buyer, I guess, if you want to.
I think it's probably so. Actually, time buyer, and then also you're leveraging, right, your body's ability to use adrenaline, cortisol to give you energy, right, acutely, right, which happens to increase insulin resistance, but it's like just the type of insulin resistance you need, right, when you need it. I mean, I don't know the exact mechanism, but anything you do to keep busy, exercise is probably a great way to do that.
Well, on that note, that's perfect. I'm going to go get me some. You guys, thank you so much. Tro, pleasure for having me stop in. Hopefully, feel free to visit anytime. this is a community that really appreciates the support. And for you guys that are looking for a doc in New York and the other few states that Tro's licensed in, I'm sure you're able. Can you see people fully remotely, or do they have to be able to?
Fully remotely.
Okay.
Fully remotely.
Perfect.
Yep. You don't need to be here.
Yeah, because I'm always getting people are asking me, where can I find a carnivore, keto, low carb friendly doc? And we've got a list of many of them. We've got a healthcare portal. We've got about 140 physicians on our healthcare portal that we're working on this platform as well. So if you're not aware of that, that's there as well. Anyway, thank you so much, Tro. Can you let people know how to find you social media wise and in any other way?
Yeah, it's at Dr. Tro, spelled out DOCTORTRO. Twitter, Facebook, Instagram, TikTok. I think I got a TikTok. The Low Carb MD podcast. Just call my office. You can go onto my website, drtro.com, and you can just start a conversation with my office manager, health coaches, medical assistants. So we make it very easy. Just reach out. We're happy to help.
Wonderful. Thank you so much. Okay, everybody, you guys have a great day. We'll see most of you guys tomorrow. Tro, have a good day. I look forward to meeting and running into you again soon. Take care.
Yeah, listen, when you're in New York, this time you got to come visit.
Okay, we'll do. All right.
All right.
Take care. Bye-bye, guys.
Bye.